So these are my disclosures, and our topic for the end of this session is, should we still be using PPIs in this time and era? Okay, so proton pump inhibitors, the story as we know it so far, these are good drugs. They've been introduced to the market around 4 decades ago and have been a staple in all medical practices across the board ever since omeprazole first introduced in the 1980s. They have successfully stood the test of time over and over again when it comes to efficacy, tolerance, compliance, cost, and as far as we know, side effect profile. The latest recommendations from AGA, ACG, and probably all the medical GI societies still include proton pump inhibitors in their guidelines. Some indications have no cap on duration and dosage of use. So why are we suddenly questioning the integrity of those innocent drugs? Why are we having concerns, and why are these concerns surfacing? While preparing for this talk, I came across this beautiful image, which I would like to call the sum of all fears. So this image depicts, or it's like a review of all the side effects that are listed in literature that can be linked or associated with the use of proton pump inhibitors. And as you can see, the drug is wreaking havoc and taking no prisoners. So what's the rationale behind us still using it? Why is it still part of our recommendations and guidelines? I think this should be taken not with just a pinch of salt, but a dollop of salt, and we should have a lot of concerns and questions in our minds regarding the safety of those drugs. Now, as far as my humble opinion is concerned, probably smoking, maybe obesity and alcoholism, probably only these can be such obnoxious to the human body. So why are we questioning PPIs? If you hit the word proton pump inhibitor on Google search, the engine keeps going and going and going as if there's no tomorrow. And there are a lot of citations and papers that depict and are loved by the press that depict the side effects and complications that are related to the use of proton pump inhibitors. I selected a few which I found a bit plausible, but I'm sure they're not all. The first section I'd like to talk about is the heightened risk of infections, and specifically intestinal infections and Clostridium difficile. So this is one of the older studies or papers. It's a meta-analysis that was published in 2012, where a group of very smart physicians decided to have a review of all the data that was out there regarding association between the use of proton pump inhibitors and the increased incidence of Clostridium difficile infection. When looking at the meta-analysis, and it was quite rigorous, if you read the paper, it was quite rigorous, the unadjusted odds ratio was 1.78. But after adjusting for all the possible confounders, the odds ratio came down to 1.27, which is quite dismal for anybody who understands statistics and epidemiology. So the conclusion of the authors was, there is a very low quality evidence for an association between proton pump inhibitor use and Clostridium difficile infection, and there is no support for the cause-effect relationship according to the grade class. A second meta-analysis which I liked was the association between the use of acid suppression and the risk of pneumonia. Now, I remember when this study was first published, it was like a hit. And I remember that every medical specialty was coming to the GI and asking them, do we still prescribe PPIs in our sick patients? Are we at heightened risk for a hospital-acquired pneumonia, or shall we just disregard this paper? So this was a study conducted in Harvard between 2004 to 2007, and it included patients ages 18 and above with a minimum admission stay of 3 days, except for those who got admitted to the ICU. So they excluded the very sick from the get-go. In total, there were around 64,000 admissions. Acid suppression was ordered only in half of them, and 3.5% or 2,000 developed pneumonia. Hospital-acquired pneumonia was around 5% in the exposed group versus only 2% in the unexposed. So the published part was the adjusted odds ratio for PPI. The unpublished part was the adjusted odds ratio for PPI was 1.3, and for H2 receptor blockers was 1.2. Again, we're talking about confounders. After removing all the confounders, this is the adjusted odds ratio. Again, it's a decimal amount or decimal percentage for anybody who has appreciation of what statistics looks like. Now, a further analysis of several studies that tried to find a relationship between pneumonia and the use of PPI shows that the highest risk is amongst those receiving proton pump inhibitors within the first 7 days of admission or presentation. And this in itself would say there is some kind of duration bias. Now, why is the spike just in the 7 days? As the longer you take the PPIs, or the longer the hospital stay, or the longer the exposure is, the risk of pneumonia decreases. And this could be explained by atypical symptoms at presentation, because as we know, all those who had pneumonia were excluded. So we're talking about people without pneumonia who develop a hospital-acquired type of pneumonia. And then there is the possibility of a prodromal illness. You present to your GP having those varied symptoms. Sometimes there's a bit of dyspepsia, a bit of nausea, a bit of chest pain, and maybe just mild cough. So not really full-blown pneumonia while the pneumonia is actually incipient. And you get prescribed PPIs before the diagnosis of pneumonia, even though you probably do have pneumonia, and that could explain the 7-day bias. And this was clearly shown in the meta-analysis of all the studies that, like 4 studies at least, that showed the relationship between the incidence of pneumonia and the use of proton pump inhibitors. All of them had a high unadjusted odds ratio, in the first one approaching 3%. That's the study I was speaking about earlier. And after adjustment, it's around, at best, 1.5. Now, leaving infections behind, let's speak about something that's closer to home, which is gastric cancer. This part of the world, gastric cancer is a concern, but it's not a huge concern. The incidence is quite low. But still, it is something to worry about. And since we use PPIs so ubiquitously, and it's given OTC and so on and so forth, it's something to bear in mind when approaching those patients. So this is a relatively newer study. It was published in 2021, and it's a UK-based study. The group actually extrapolated the information out of a database that included all the UK population. And they just looked for the new users of proton pump inhibitors and the new users of H2 receptor blockers. The follow-up was around 5 years. It is a retrospective study, it's not a prospective, so follow-up was around 5 years. And initially, prior to adjusting the odds ratio, the incidence of cancer was higher in the H2 receptor blocker group. After making all the adjustments for the confounders, the group came up with an association of an increase of 45% in the incidence of cancer in patients using PPIs, with a hazards ratio of around 1.5. Now, I don't know how to take this piece of info because the confounders were there at the beginning, not just at the end, and they were risked, assessed, and looked at from the beginning of the paper. But anyway, the number needed to harm, though, was quite high, and it was prevalent after, or very obvious after, the first 5 years of exposure. And their explanation for this finding is that once you start taking PPI, the damage that happens to your gastric mucosa is irreversible. So there is no way going back. It'll just progress. So the take-home message from this paper is that there's an increase in the incidence of gastric cancer. So the weapon and the shield are actually a culprit over here. Now, PPI and cardiovascular disease. This is a more interesting paper because it was a prospective one. It was part of the COMPASS trial, and the COMPASS trial was actually a paper or a study to assess the safety of NOACs in decreasing morbidity and mortality in cardiovascular heart disease. So prospective design, March 2013 to May 2016. I'm talking just about the P arm, where the PPI was used. It was around 18,000 patients and a 52,000 follow-up patient years of follow-up. The duration of follow-up was only 3 years, but 3 years is not a bad duration for a prospective study. So they looked at the risk of MI, stroke, any kind of cardiovascular related death, MI on its own, stroke on its own, all new cancers, GI cancers, all hospitalizations, and all-cause mortality. And interestingly enough, when the study became prospective, the risk of GI cancers was almost minimal. The hazards ratio was only 1. And so was the hazards ratio for everything else, including the study, comparing the use of pantoprazole to placebo. So the authors deducted that the number needed to harm is huge. And for certain outcomes, I did not mention them, like infections, the power was very, very small because basically they were not seen. There was no mention about the dose, so are we talking about specific dose that can harm you or no? There was no mention about this. And they were unable to exclude the harm related to smaller dosages or a smaller duration of intake. Now, they also suggested that probably adverse events may take longer than 3 years to happen, going back to the fact that PPIs can have an irreversible type of damage on different parts of our body. So something kind of newer related to the tornado that hit us around 3 years ago. So the Danes were a bit smart about it because the headlines had initially insisted, or the media was like, PPIs increase the risk of COVID infection, PPIs increase the risk of you catching COVID infections. So the Danes did a nationwide observational study, and they included all their COVID patients from the period of February to December 2020. This was around 83,000 patients. And what was investigated in this paper was the risk of severe outcomes, including mechanical ventilation, ICU admission, or death in current PPI users. So they were not new PPI users, they were current PPI users. So they came up with the association that there was an increased risk of hospitalization. However, there was no increased risk of severe side effects. Following that, a meta-analysis was made of 10 studies assessing the link between the use of proton pump inhibitors and the severity of COVID-19 infection. And here, the pooled odds ratio was only 1, and the relative risk was only 1.33. So this review included 10 studies. We are talking about around 1 million participants, and there was no impact or risk of COVID with an odds ratio of 1, which sounds very reasonable. And if you can see over here, only the smaller studies out of these had a higher signal and a higher odds ratio for linking the risk of COVID-19 infection and PPI use. And probably because the numbers were small or the confounders were not kept into consideration, I have no idea. So before we reach the take-home messages, whenever we'd like to make an association between two factors, a stimulus and an end result, there is something called a theory of inference. And the Bradford-Hill criteria is a well-known criteria for all epidemiologists to make a connection between one thing and another. And if you go back to the first slide, PPIs were implicated in basically any condition that can affect any part of your body. And this raises a lot of concerns because one of the criteria for inference is specificity. And this is not seen in almost all papers related to PPI use. Again, we cannot really decide on a duration that can be toxic. We cannot decide on a dose that can be toxic. So, and we cannot really have a consistent toxicity-related paper. So, are we really? Is there really a connection between the use of proton pump inhibitors and all the risks and complications that are mentioned in literature, or is it just what the press and the media likes us to know and what scares your patients on a daily basis? Now, as I said, I'll make it short and sweet, so we'll go for take-home messages. Feel free to look up all the data there is about proton pump inhibitors and their side effects. As I said, I chose just the ones that I liked. So what I think should happen is we should all be interpreting this data reasonably. As I said, take it with a pinch of salt or a dollop of salt or just with a bit of sense, and then utilize it in your daily practice. Now, as in everything else in life, if something sounds too bad to be true, it usually isn't. And in most cases where papers were published showing a link between proton pump inhibitors and a toxic effect, there are definitely other confounders and more potent and more reasonable and possible confounders. So saying that, we should not neglect or overlook the possibility of a modest degree of harm. So always do things reasonably, always do things with sense. Now, recommendations, latest guidelines, they do recommend that patients on long-term PPI should always be reviewed on a regular basis and de-prescribing attempted once feasible. Remember, use your proton pump inhibitors for the appropriate reason, not just because a person has tummy pain. Use it for the appropriate reason and in the appropriate dose. Always discourage inappropriate use. So PPIs are OTC drugs. Make sure your patients are aware that they're not supposed to use them forever. And if they decide to start using them, they should seek medical opinion. And last but not least, these drugs are good. These drugs are effective. They might cause complications. Nothing doesn't. There is no safe drug on earth. These are all poisons that we're taking in our bodies, but remember that when used for the right reason, for the right duration, at the correct dose, they are really good drugs, and that's how it should be done. Thank you.